But in general, I think poor discharge planning is that top contributor. And by that, I kind of mean like discharge planning that doesn't assess a patient's educational level, their support at home, what resources they have, like transportation and finances, and then to go further, evaluating if the patient even understands the reason they were admitted, and then how to manage their care once they leave. Only so much we can treat in the hospital. What happens at home is what we need to prepare our patients for.
You're listening to the Oncology Nursing Podcast, where ONS Voices talk cancer, a resource from the Oncology Nursing Society. Through conversations with subject matter experts, we examine the important issues in oncology nursing, from new treatments to patient-centered research to advancements in clinical practice. Join us as we hear from nurses in all facets of oncology care, from bench to bedside and everywhere in between. Welcome to the Oncology Nursing Podcast. Hello, and welcome to the Oncology Nursing Podcast. I'm your host, Jaime Weimer, Manager of Oncology Nursing Practice at ONS. And today we're talking with Stephanie Frost, Manager of Outpatient Clinics at City of Hope Cancer Center, Chicago in Illinois, about strategies to reduce hospital readmission rates and emergency department visits in patients with cancer. As a reminder, you can earn free NCPD contact hours after listening to this episode and completing the evaluation we've linked in the episode notes. Welcome, and thanks so much for joining us today, Stephanie.
Thanks for having me on. I'm so excited.
Wonderful. Well, let's start off by covering some of the basics. Patients with cancer can be hospitalized for a variety of reasons. It might seem obvious, but why don't we want patients to be readmitted unnecessarily after discharge?
First and foremost, it's just that negative impact on the patients. We all know that patients come first. That's why we're oncology nurses, right? Because we care. We want our patients to stay on track with their treatment regimens and ultimately have a better quality of life. Admissions and readmissions get in the way of all that. It puts patients at higher risk for poor healthcare outcomes like infection and blood clots. And then it also has a big financial impact on our patients, adding to the stress that they already are dealing with. And then I would say on top of that, it's just that impact and the burden to our healthcare system. As you stated, these are unnecessary admissions. So there is that impact to reimbursement. It can impact our quality indicators. And then, of course, staffing and ratios.
So why are readmission rates an important quality measure for health systems and hospitals?
I mean, of course, readmissions are inevitable, but ultimately high rates may indicate that there's a problem, right? Something is wrong. The quality of our care is not up to par. So looking at the rate of unplanned readmissions encourages hospitals to look inward, see what's going on, and find the gaps. Ultimately, we shouldn't be admitted right after we're discharged. So if readmission rates are high or they're increasing, it's time for the system to look at ourselves and ask ourselves questions like, are the patients understanding their discharge plan? Is the care coordinated from inpatient to outpatient? Do the patients have the support they need at home? Are we discharging patients too soon? So it just should trigger that automatic response that improvement is needed.
So what are some of the most common reasons for readmissions in patients with cancer?
This is a complicated question. I mean, we know cancer patients have intricate needs. Not only are they undergoing treatments that can cause challenging side effects, they also have comorbidities like the rest of us. So when they experience side effects of treatment like anemia, dehydration, GI issues, fever, infection, it's compounded even more. And then I think it's also complicated by what patients feel that they can take care of at home versus what they would rather do in the hospital setting. You know, if their doctor is at that hospital and they trust them, they're going to want to go back to be treated by their hospital over trusting themselves to care for themselves.
That's a really interesting thought that I don't know that I thought about before, but you're right. I mean, what we ask of patients, even beyond cancer, is it's complex. Healthcare is not simple. And so there is that element of just safety and feeling comforted by knowing the people that you know and trust are there helping you through it. But unfortunately, that's not how our healthcare system is set up to allow people just to come back so that we can take care of them. Sometimes we do have to help them take care of themselves at home. But that is an interesting point.
Absolutely.
What are some of the risk factors for readmission in patients with cancer?
I think some is dependent on their reason for admission. So for surgical patients, the length of their hospital stay, the amount of their comorbidities, how advanced their cancer is, or any post-op complications, of course, can increase their risk for readmission. But in general, I think poor discharge planning is that top contributor. And by that, I kind of mean like discharge planning that doesn't assess a patient's educational level, their support at home, what resources they have, like transportation and finances. And then to go further, evaluating if the patient even understand the reason they were admitted, and then how to manage their care once they leave. As I mentioned earlier, like only so much we can treat in the hospital. What happens at home is what we need to prepare our patients for.
So how can nurses and other healthcare providers help to identify these patients at high risk for readmission?
Number one thing we can do is review the patient's social determinants of health. We're seeing this assessment tool used more and more in the hospital system, and it can truly help identify high-risk patients. I just recently became more familiar with this topic, so I'm just kind of going to do a brief overview, but it really takes into consideration a patient's environment, and it includes 5 components. So access and quality of education, economic stability, healthcare access and quality, home environment, and then the patient's community. So basically, it's reviewing if a patient has a support system. Do they have money to buy their medications? How are they getting to their appointments? And then when we look at the education access and quality, it has its own set of challenges. I think teaching the same information can be a little routine for nurses. We're hearing the same thing day after day, but it's mostly new information for our patients. And if they don't have healthcare experiences or aren't at like a reading level that allows them to understand the education we're giving them, what good is that for the patient? So I think you just add that into a patient who's having a ton of physical and mental stress. It's just very overwhelming. And it's just something we have to keep in mind when we're addressing patients who are at high risk.
I think that's so important. And as you said, it is, something that I think has gotten a lot more attention in the recent years, deservedly so. I think for so long, there was a focus on making sure that we told them the right stuff, make sure that we told them what they need to know. But did we ever ask the question, but do they have the means to do it? The means could be many things, like you said. It could be financial, it could be access, it could be support, it could be education and comprehension. But it's just like those are two sides of the same coin. And so us just making sure we checked all the right boxes and gave them the right educational handouts. And again, I'm not saying that as though nurses are at fault for that, but that was sort of, I think, just the mindset of just making sure we told them all the right stuff. And now I think we're appropriately asking that question and giving more focus to, okay, but do they have what they need to implement what we're telling them is important? And so I think it's so important. Thank you for providing that definition, because I think that is where we need to focus for our patients. So what are some of the challenges and solutions to help identify these high-risk patients?
I think it's exactly what we're talking about, the complexity of cancer and the complexity of humans, right? So lung cancer isn't just lung cancer, and each patient has different support and resources. So it's just so hard to generalize to identify high risk. Even like you said, using the social determinants of health, we can do that assessment all day, but if we're not having the right people look at it and the right follow through, it's not really helping us. So that's definitely something we struggled with at first. We didn't even look at that at first. Actually, at first we looked at like patients who were at high risk for like chemo regimens that were intense or harder for our patients to tolerate. And then we wanted to look at those aggressive cancers. So we kind of did our own homegrown risk assessment tool for that, but we found it's not inclusive enough. There's so much more to consider. So we really changed our focus to looking at preventable and treatable symptoms. So patients were reporting those when they were going to the ED. So we just really changed our mindset to that perspective. And then one of the challenges we actually found too is our patients were self-reporting to the ED. So our oncology nurse navigators, we weren't even aware that the patients were being treated or given the opportunity to triage or do management. So to capture these high-risk patients, we had to get our ED nurses involved, our outpatient nurses involved, inpatient discharge planners. So basically our solution was just to get everyone involved.
Appropriately so. It is a team sport when it comes to caring for patients with these serious health conditions, diagnosis, cancer, of course, fitting into that category. That's great. I can't wait to hear more about the program that you stood up. Before we do that, though, how should oncology nurses educate and prepare patients, not only the patients themselves, their care partners, their family, throughout an entire hospital stay as they approach that transition back to home to hopefully prevent these readmissions?
One of the most important things when I was connecting with our discharge planners before coming to talk to you today was they said it's most important to review the appropriate contact information. Who should patients call for help once they are discharged? And that includes details on what hours someone's available and that no question's too small. Like we mentioned, if we don't know about it, we can't help. The second most important thing is educating patients to the reason they were admitted in the first place. Patients need to understand what happened to get them in the hospital and what is being done to manage that problem. I'm sure we can all think of an example where, a patient's being discharged and they're taught something that same day, and then they get home and they just panic without nurses around them. And so, like you said, that's why the education we provide needs to start early on admission, needs to be reinforced through the entire hospital stay, at discharge. And then what our discharge planners do is that follow-up call, making sure it's an ongoing effort. Ultimately, it just comes back to if the patient can independently manage their care before they leave the hospital. And if not, do they have the support and resources? We have to just encourage our patients and prepare them really to be independent and have that accountability.
Absolutely. And, again, this is just a reality of so much complex care being shifted to outpatient. There once was a time maybe where all of this was done inpatient, and we wouldn't send patients home until they were really tucked in and perfect and ready to go on their healing journey. But that's not where we are now. I mean, we have to move them home and care for them as much as we can in an outpatient setting. And that's very complex. And as you said, we're trying to educate their patients, family, their caregivers, who's there to help support them. I can only speak for myself, as I think sometimes, I lose sight of what that means. I'm just so immersed in what it is to be in healthcare and all the terms and it's just the second nature for us as nurses, because we just live in it all day, every day. But I think what some of us have found is that when you are in that other position, when you become the patient or your family member becomes the patient, I think that's when we start to glaringly see, oh, wow, this is really hard. This is really complex, and we're asking a lot of our patients. And so while I certainly would never wish that on someone only to get that perspective, I think that can sometimes be a pivotal moment in healthcare providers' experience and their role in healthcare of just suddenly recognizing and acknowledging it's really hard for those patients that don't have somebody there with that understanding in the healthcare environment. So I think it's really important, as you said, to think through that and be preparing patients for what it is to take care of themselves at home, but then also know kind of what is your lifeline. If you do have questions or there are concerns, who do you call and what's some important information to be watching for and to be sharing with those healthcare team members when you do make that call?
That's so true. Actually, my dad came home from the hospital the other day, and when I asked him, what did they tell you or what are you supposed to do? He was like, oh, I don't know. And I'm like, okay, well, did they give you a number to call? I don't know. And it's like, so I think so many patients just don't even, if they don't understand, they don't even know to ask more questions. So it's just can be such a scary thing.
A similar story. My mom had a foot surgery, nothing, not serious, but I don't know that anyone ever asked her, do you have stairs at home?
Right.
How are you going to be mobile and get into your house if you have stairs to get there? So again, I think everyone's trying to do their best, but some of these things are it's hard to really comprehend until you are on that other side and you realize, wow, these are really important questions to be asking so that we're sending people home equipped and ready with all the information and resources they need to be successful at staying home. Let's get into your project. You were part of a quality improvement project that was addressing readmission rates at City of Hope Cancer Center in Chicago, which your team presented as a poster at the 2024 ONS Congress. Can you describe about your project's specific goals and the oncology nurse's role in developing and implementing the project?
Ironically, the goal of the project was exactly what we've been talking about. It's identifying those high-risk patients for admission. We wanted to have a standardized process to increase touch points for patients with the goal of then, of course, reducing healthcare utilization and costs and increasing patients' quality of life. So the project really stemmed from our quality director. She's an OCN certified nurse, and she was reporting out OP35, so those patients getting chemotherapy and going to the ED, and then readmission metrics at our practice quality council. And so from those metrics stemmed the opportunity to do some digging. So we had a small subgroup of oncology nurses that did chart audits, and we found that many of our ED evaluations were, one, patients showing up for treatable conditions, such as nausea, vomiting, dehydration, and pain. And secondly, like I said before, our patients were self-reporting. So this kind of led us to believe that, there's this whole group of patients right now falling through the cracks, and we just had opportunity to increase touch points and improve that coordination between departments. So we pulled together ED, inpatient, outpatient, and really wanted to improve that communication. In addition, we'll talk about it a little bit further, I'm sure, but we had this program, a virtual continuous care program. We pulled together all those departments and developed an educational tool for referring to the program, and then did more audits just to make sure the process was hardwired.
Let's dig a little deeper into that. So you enrolled some of your patients in your hospital's continuous care program. Give us a brief overview of what that program includes and what does it provide for patients?
It's a virtual program which oncology nurses develop a personalized care plan. So based on that patient's care plan, these oncology nurses would follow up with the patients on a regular basis, and they would check in on things like, are the patient's comorbidities being managed? Does the patient understand their medications? They assisted with symptom management. But to me, the most important thing that they did is they provided coordination of care with local providers. So they didn't replace what our oncology nurse navigators in the clinic were doing, but they really added that extra layer of support, especially for a traveling population. At our hospital, about 50% of our patients are from out of state and travel to receive treatment. So as you can imagine, it has a whole slew of challenges with coordinating care across state lines. So the continuous care program really filled that gap for us and addressed those specific barriers for traveling patients.
And that's so important. I appreciate sort of the slight distinction that you sort of brought to the surface there is that we have the navigation role in many places. Thankfully, it's such an important part of a patient's care because it is so complex. But sometimes that navigation role is really just focused on the complexity of their cancer care and how they have to go from different specialties and here and there and coordinating diagnostics and follow-up things. But that doesn't always necessarily include the coordination and the navigation that is needed to bridge their cancer care with everything else that we now know. Well, of course, we already know it is so important. And as you've talked about, can influence and be what's underlying some of these readmissions. And so it's so great to hear that your program has that sort of focus of coordinating that care back into the community where the patients are living and recovering. Because sometimes, a single navigator can't do all of that. And so it sounds like you guys have this separate program that is helping to kind of bridge that need between not only the complexity of care in their cancer treatments, but also the complexity of bringing that care back to the community where they live.
That's exactly it.
So a major part of your quality improvement project was engaging in regular communication with patients after discharge. Explain the nurse's role in those check-ins and how often were they conducted?
So we definitely increased our touch points by our oncology nurse navigators. We implemented 4 different strategies to check in with patients. The first example is contacting those patients that were evaluated in our emergency department. So our ED team would send our clinic team a message to alert them that they were evaluated. But that's really when that oncology nurse navigator took over, reviewed the chart, looked at the reason for eval, looked to see if there's any orders we needed to carry out or schedule, connected with their medical oncologist. They would do all of that and then contact the patient within 24 business hours. During the call, they would just want to make sure that the patient understood their discharge instructions, review any med changes, and overall just check in with the patient. I have an example recently. We had a patient that was seen in our ED for nausea and vomiting. And then due to that follow-up call the nurse made, she was able to get another set of labs drawn on the patient, found that they had an electrolyte imbalance, and then got the patient set up for fluids in an outpatient setting. So I think that really prevented that patient from going back to the ED, probably for the same reason they were there in the first place. The second touch point I wanted to mention was just re-education during our clinic visits. Our teams were already performing calls after the patient received treatment 7 to 10 days later to check on symptoms. But now our nurses just started to prep and focus on educational opportunities. So if that patient complained during the call about a symptom, or if they were calling our care team multiple times between cycles, they would flag those patients and then see them during their clinic visit to reinforce medication adherence and nursing interventions, and just to really do re-education in person. Thirdly, it was our discharge follow-up calls. So our discharge planners also identified patients who were high risk for readmission. Using those social determinants of health, they considered the patient's age, if they had DME necessities. So if it was determined that the patient was high risk, they would contact the patient 24 hours after discharge and then place a second call 48 to 72 hours after discharge and then hand off to the care team. And then lastly, at all 3 of those touch points, our teams would refer to that continuous care program we talked about. They would review the patient, determine if they're a candidate, and then if appropriate, they would continue to coordinate care for the patient.
Sounds like an amazingly comprehensive program, just using every opportunity, again, as you said, to reinforce education, to validate any other needs that haven't been addressed as part of the last visit they might have had. just really a great way to make that patient feel like they are looked after and noticed. And, again, that proactive check-in with patients of trying to catch things before they become problems, or maybe before the patient even recognizes that it's something they should be talking about or they should be calling for. So just really a great program. Thank you so much for sharing this with us. So it sounds like the electronic health record was probably a pivotal tool in this program. Talk to us about how you use the EHR system to facilitate communication or identify these patients and flag them for being at risk for readmission.
Just like you mentioned, the most important role for us, the EHR, was that interdepartmental communications. While each team was already doing their role and documenting their interventions, we use that secure health messaging to send messages and alert other departments, hey, this patient was seen in our area, and provide a handoff. So both the emergency department team and the inpatient team would do this as the patient was leaving. So this was huge in just identifying those patients that were high risk. And then it allowed us to follow up with increased touch points. We also used a tasking system within our EHR to put reminders in and put specific dates of what we needed to follow up with and on who. The second thing, which was really nice, it was an automated feature, was that our EHR would send an automatic task to the care team 7 to 10 days after the patient received treatment so that they can contact the patient. And that was triggered by our infusion nurses completing their treatment in the MAR. So it was just a nice automated feature for us to flag the patient and start tracking them. I think the biggest challenge and gap we had was just knowing what the other hand was doing. So the EHR really just allowed us to do that handoff.
I think that's so important. I think we could probably have a separate episode about all the problems with the EHR, but I think you've right now highlighted some of the great benefits that really we couldn't do without having that shared system across departments. The ability to create those automated flags, those messages, ways to communicate across departments, across shifts, sometimes across buildings, if patients are going to different locations. And so it really does just, I think, identify the importance of leveraging and really being able to wield the EHR as a tool, not just as a place for documentation. And that comes with its own challenges. We don't always have the ability to perfectly customize it to our very unique but important needs. But it sounds like your team was able to achieve that by working collaboratively across departments. So how did you measure the outcomes? How did you know that it worked? And what are some of the key results and next steps for the program?
Well, when we reviewed the data, we saw our readmission rates had dropped by 51% at the 6-month mark. And same with our ED visit rates. And then our referrals to the continuous care team jumped 155%. So obviously we can't be mad at those numbers.
Right.
But we were able to discover some other opportunities through the process. So for example, through the chart audits completed, we were able to identify an increased need for our pain management services. So there was a large number of patients that the reason for visit was pain. So we ended up expanding our templates for our pain management providers to meet that need and ultimately reduce the admissions for pain. We also were able to look at our infusion templates to accommodate same-day add-ons for hydration, blood products, to prevent those patients from going to the ED or becoming more symptomatic. And then since our implementation, we have moved to a new EHR. So like you said, a whole new fun set of challenges. So now we're just looking into that, adapting and continuing the process. But hopefully our new EHR system will have some more automated features. Our auditing and reports right now are very manual. So we're really hoping that the new EHR will streamline that communication and data collection for us. But what I'm most excited about is the focus on our nursing education and phone triage. So throughout the project, we found that our oncology nurse navigators had a variety of experience, both with phone triage and also oncology. So we wanted to provide additional support for our newer nurses, but also establish some best practices when it came to phone triage. So this request actually came from our unit-based council for our outpatient clinics, and then using staff survey results, our nurses were just wanting more education and support in managing systems. So when they investigated evidence-based tools, they found ONS's telephone triage for oncology nurses book. So we connected with our education department, and we're planning to use this book as a guide for an in-person course, and then also for future competencies for current nurses who have been here for a while. So We have a few OCN frontline nurses working with our educators right now to develop and teach the course. So kudos to ONS for that tool. We're really looking forward to that. We're thinking, if we can improve the competency of our nurses in managing symptoms, being proactive, doing those nursing intervention, we can ultimately reduce ED evaluations and admissions.
Man, my secret favorite topic is triage. So exciting. I love to hear that. And I think it sort of underpins all of the things that we've talked about today, is just acknowledging that we're managing patients from home and we have to make sure we're teaching our nurses the skills and the knowledge necessary to do that, because it's a very different way to assess patients that were not necessarily taught in our undergraduate programs. Not having the ability to see and put hands on a patient like that, it requires just a very different skill set. And so you're absolutely right that doing some focused work to provide that education and make sure that nurses feel confident in their ability to do it, such an important step.
Exactly.
Well, Stephanie, thank you so much for joining us today on the episode. Such a great program that your site was able to roll out, and it sounds like doing great things for your patients and for your community. So thank you so much for sharing that with our listeners today. As we come to the end of our episode, we always like to wrap things up with a series of quick fire questions to help summarize some of the main points that we've talked about. So to start that off, how do you think healthcare professionals can evaluate their hidden or their implicit bias when it comes to readmission rates in patients with cancer?
I think the first part is just increasing your own awareness of your own opinions and on the reasons patients are getting admitted, and then compare it to the data. I know my initial assumption was that our nurses were directing patients to the ED versus using nursing interventions and triaging. But when we looked at the data, it showed that patients were self-reporting. So we weren't even, like I said, given the opportunity to triage. And I think we've heard other biases in the general public related to pain management and pain-seeking patients, as well as populations using the ED or hospital services instead of outpatient services due to insurance coverage or costs associated. So I think being aware of what common biases exist can help us evaluate our own underlying bias. There's actually a great article in the Journal of Advanced Practitioner in Oncology, and it's called Uncovering and Addressing Implicit Bias in Oncology, and it outlines actions that every individual or healthcare organization can take, including education and resources on providing culturally competent care. They even reference a testing tool about implicit association test, and that's where you can compare your own progress and growth to associations you unknowingly make. And then we have a really robust program at City of Hope on addressing diversity, equity, and inclusion. So it's just that should be required of all healthcare professionals and facilities.
What are some common misconceptions about reducing readmission rates?
I would say differing opinions on what is an unnecessary admission or what is considered avoidable. I mean, I think in our own facility, we have differing opinions from staff and departments. So if one organization can't be on the same page on what that is, I can only imagine what the variety of opinions across oncology are. I think the other big misconception that we kind of talked through is the solution is simpler than it is. I mean, if you're looking what our project was intending to do, while we make great strides towards decreasing readmission rates, there's so much more opportunity and growth there.
What's something about this topic that's not often discussed, but you wish people knew more about?
For me, it's the importance of continuity of care and collaboration. It can be a challenge not only within one hospital system, but working in a specialty cancer hospital, our patients do receive care in a multitude of other places. And like we said, a lot of them are traveling across straight lines. So I think what's best for our patients is that their care provider, who is helping them make these huge life-changing decisions, be fully aware of everything that's gone on since their last visit. The other piece is that we're not alone. I think oftentimes us nurses try to bear the weight of a patient's needs on our own, and we don't have to. We should be using our resources. For example, we just recently increased our social work support at our location. The services and expertise that they can provide is unmatched. Our nursing teams don't have the capacity or the knowledge to assist at that level. So it's trusting other professionals to contribute. It's trusting that interdisciplinary team can help patients through transitioning.
What additional training or education do oncology nurses need to stay current on this topic?
For oncology nurses specifically, the best focus would be on prevention and what we can do to care for the patient before it results in admission. I think increasing our knowledge on the social determinants of health and incorporating that diversity, equity, and inclusion training and how we respond If you go to health.gov, there's so much information about those things, and it includes evidence-based resources that you can apply to your own setting. As it relates to nursing interventions, ONS has obviously a multitude of resources. ONS Voice, I recently read an article about symptom management strategies, and then also the ONS symptom interventions and guidelines nurses can use to reference and advocate for patients.
And what are some additional resources maybe for patients or other providers who want to learn more?
One of the best places I have found is the National Cancer Institute's website for patients. If you go to cancer.gov, there's a whole section specifically for patients, and it gives them information about treatments, side effects, and then for just resources about life and healthcare and support in general, I'd say it's the organization 211. You can literally go to 211.org or call 211. It's available 24/7, and it gives patients and caregivers resources for mental health support, food programs, assistance with bills, housing, expenses. But I'd say for patients, reach out to your care team, reference the education specifically given to you. And I would also encourage patients to reach out to social workers. Your social workers in your organization should know of resources in your area that would best meet your needs.
Well, Stephanie, thank you again for joining us today. I'm so excited to hear about the success of the program that you've been able to implement at your site. And just hopefully, listeners will hear that and maybe be inspired to consider what can they do with their own site. So thank you so much for sharing. Do you have any final comments to share with our listeners today?
I would just say, do your research, look for that evidence-based tools that are already out there. You don't have to recreate the wheel. We've learned that with our project. And secondly, just reinforcing that proactive education and repetition. And maybe I'll be back to talk to you about phone triage next year. But I thank you so much for this experience.
Wonderful. Thank you so much. Thank you for listening to the Oncology Nursing Podcast. Tell us about your favorite part in this episode by leaving a review wherever you download your podcast. For more resources and information about oncology nursing, visit us at ons.org or voice.ons.org. The ideas and opinions shared in this episode represent those of the guest and not necessarily ONS.